I was invited to speak at Paris, and it's the International Oncology Leadership Conference, and I submitted, a lot of this is about how to solve big problems in oncology and to bring a group of leaders together from across the world. And once I just found an application on LinkedIn, and I thought, I am such a huge proponent of survivorship, I thought they should hear about survivorship. And before I even realized what I was doing, I got my friend Veronica, who is Director of Programming at the National Coalition of Cancer Survivors, who lobbies for you in Washington, D.C., and we submitted it. And then in the next day, I went and looked, and the previous speakers had included presidents of foreign countries and ambassadors. And I was like, okay, well, I'm not going to get picked. And then the man emailed me and he said, Dr. Wentworth, I've read your work, and I've read your work about working with lung cancer survivors, and that's something that I think that people need to hear about. So I'm going to Paris because a couple of really wonderful lung cancer physicians took a chance on me and started advocating for you. So this is Cassandra Beaugrand, who was the women's triathlete gold medalist. She's a French athlete, and this was the picture that the photographers took as she crossed the finish line. And I think as doctors, this is what we see of our patients, and this is what we see as survivors. We love the pictures of you guys ringing the bell or walking out of the clinic for the first time, so happy to leave us. And this was a picture that a journalist took of her about 5 seconds after that picture was taken. And talking to all of you and talking to your caregivers and co-survivors, this is what I think we miss in medicine is, although this may not be you on the outside, it can be you on the inside. And so I do want to say that especially in the lung cancer community, you all in this room are on the edge. You are seeing things that your doctors may not see, that healthcare may not see, and that other people may not see. So when you look around this room, you're in a bunch of people that speak your language and have heard the things that you have seen. But I want you to know that most of the time, the healthcare community is seeing this and is not seeing this. So if you look around and you think, why doesn't anybody understand? That really is because you are on the outer edge. You are Lewis and Clark. You are Neil Armstrong on the moon because you're experiencing different things. So I'm here to validate that experience for you. And it is only through the work of Dusty and other lung cancer advocates that my eyes have been opened to the lung cancer survivor experience. So I present to you humbly, knowing that you are teaching me just as much as I can add anything to what you're learning. So as Dusty was saying, cancer survivorship is not something, I never heard about cancer survivorship. I finished my training in 2009. And I know you think she's too young, but that's true. And I never heard anything about lung cancer survivors. What I heard, it was well known that you couldn't cure lung cancer. Occasionally, you'd get a patient who had a knee replacement or a hip replacement and a nodule was found on a chest x-ray, but that was the anomaly. There was no such thing as a lung cancer survivor. Maybe once or twice a week, you would have a lung cancer survivor in your clinic. And that was the same, I have to be honest, with other cancers as well. We could fit our survivorship clinics or our long-term follow-up clinics into an afternoon a week. And that has really changed over the course of my career, over the course of the past 15 years. And there really is a huge increase in lung cancer survivors and survivors in general. So it is true now that 1 in 3 Americans will be diagnosed with some form of cancer. Almost 5% of the population of Europe is a cancer survivor, and cancer survivors are growing. Particularly as it relates to lung cancer, as you're hearing and seeing more lung cancer survivors, really, you guys are on the precipice and on the edge. You are leading the way for many, many, many millions of people that are going to be following you. And that's because of advances in treatment. So deaths among lung cancer have been falling, mostly related to early detection techniques from 2006 to 2013. And 2013 was when we really started looking at immunotherapy, about using the body to fight the cancer cells that are inside of us and part of us, rather than working against the body by poisoning it with chemotherapy and that sort of thing. So 2013 was really when we started to change our approach to cancer. And you can see that now. And you hear about, I mean, we have so many more tools to treat and cure lung cancer than we used to before, that the survival rate, the death rate is actually decreased by 100%. We've doubled the survival rate, and that is both in men and women in particularly non-small cell lung cancer. And because of that, this is what I call the existential crisis of survivorship. Dr. Fitzhugh-Mullen in 1985 wrote the first seminal paper about survivorship, and it was in the New England Journal of Medicine. And in 1985, no doctor is going to believe anything unless a doctor says it and unless it's in the New England Journal of Medicine. So he really said this, which I think is true. And I think it's worth just thinking about, despite the successes on the treatment front, we have done very little in a concerted and well-planned fashion to investigate and address the problems of survivors. It's as if we have invented sophisticated techniques to save people from drowning, but once they have been pulled from the water, we leave them on the dock to cough and splutter on their own in the belief that we have done all we can. And I think that is the survivor experience. And I will say that when we are trained, and still in the residents and fellows, 90% of our training is trying to save your life. 10% of our training is in screening, prevention, and the care of cancer survivors. So I think that because of that growth and that exponential growth in survivorship that we're seeing, that there is an awareness that we need to do more, and we need to think about what's happening to our patients after treatment. This is a survey that the National Coalition of Cancer Survivors does every year. I encourage you, there were about 2,000 respondents. They send it out every fall and ask different questions. Here you can see that during treatment and these are all cancers, during treatment about 90% of patients experience some form of symptom. The more interesting number, I think, is that almost that same number have symptoms after treatment. And we don't really think about that. And sometimes the people around you may not think about that because it's over, right? The celebration, you're a survivor, you fought the good fight, it's all over. But in your hearts, and this is what you've told me and the people that work with me in the survivorship space, you know that there are still things that your body's healing with, and there are long-term side effects that you live with every day. I will say this, after cancer is very specific to you, and you all should know that, and that's going to be particularly true as we move forward with more personalized treatment. So it's going to depend on the type and stage of cancer that you've had, your particular treatment, and then your health before and after treatment. So sometimes patients will say, I feel guilty because I have this cancer, or I had a young mother who had thyroid cancer, and the treatment for thyroid cancer is not difficult, but after treatment and preparing for surgery is very difficult. And she said, what do I have to complain about? I'm 24, I have a curable cancer. Why should I be complaining? And I just looked at her and I said, suffering is not comparative. And I really invite each one of you to just say, this is your experience, that being a survivor is not good or bad. It's just being a survivor. It just is. And so I think that acknowledging that everybody is going to have a different experience is really important. I'd like to talk about relationships. I just left and had a fight with my husband on whether we were going to check luggage or not. So we can go into marital counseling later. But sometimes I think that it can feel like doctors and patients aren't communicating. And I will say that from the doctor's perspectives, what we are trained for is medical surveillance. So it is to bring you in, to do a CAT scan, and to say whether your cancer is back or not. And that is really the extent of most of our quote-unquote survivorship training. So if you feel like, oh my gosh, I'm asking these questions and my doctor doesn't know the answer, that's a correct experience to have. One, because we don't have a lot of research on what is the evidence-based practice for caring for lung cancer survivors, and also because we're not trained in that. So I'm going to give you a few behind the scenes how to crack the code of the doctor-patient relationship. So first of all, I'm going to tell you sort of where we, like this side of the exam room, when you guys are sitting on that side of the exam room, this is what we are trained to cover in a follow-up visit. That's reviewing your medical history, asking very specific questions, looking at some physical exams. Some of you might be getting bronchoscopy. Some of you might be getting CAT scans. And then I think we need to be aware that as, again, lung cancer becomes more personalized, that you may be asked as part of your screening to do things like spit testing or sputum testing or blood testing, similar to the way that we do pap smears and PSAs for other cancer. I think we're very close to having liquid-based cancer detection tools. So those, you may start seeing those come into your follow-up visits. We are really looking at the effectiveness of your treatment. That is the view that we bring into the follow-up visit. Do you have cancer coming back or not? Do you have any side effects? And those are side effects that we're trained on, not side effects that are important to you. And if there's the very few late effects that we learn about our treatments. The doctor-patient relationship from our perspective may not include a discussion of how to manage those side effects. So when you say, hey, I've got this thing, and they're like, we rarely will a doctor say that you are cured. And we, as our systems become ever larger and more complex, we also become less connected. And I think that coordination of care back with your primary care physician is not something that we do very well. And we also, I think, don't explain symptoms or why they're happening to you. One, because a lot of the times we don't understand it. And again, if you go back to what we're looking for, the filter that we're trained in is this cancer or not? If it's not cancer, it almost goes into this other bucket where our brain turns off and we're like, yeah, it's not cancer. That's all I can tell you. So I think when you're going into those, and we'll get to what to do about this, so this is not all doom and gloom, but I do think it is important to go back to your primary care physician and to utilize that person. As oncologists, we are so specialty trained that we lose perspective. I mean, I only did a year of general medicine before I started training, learning about treating cancer. So our view is very limited of what we know, whereas general practitioners are really much better at looking at humans in a more holistic way. I wish oncologists were like that, but mostly we're trained to look at just the cancer piece. The second part is just to continue to be active, and that is activity for you specifically. So that may be limited by your surgery, by your lung disease, by side effects of treatment, by heart disease, but any movement of a body. We're learning more and more about the microscopic and microvascular improvements in health that happen at a very cellular level. So moving our bodies, even in the smallest ways, is always good. So patients often ask me, okay, but I have this thing that's really important. Like, what do I say to my doctor? And these are 3 key phrases that you can practice in the mirror. And I will get sort of towards the end of the talk on what to do if, you still don't think that your doctor really is listening. But the first is, these are sort of red flags in front of a bull. I need you to stop and listen to me. And the first is, I need to tell you something that will help you take better care of me. You guys want to repeat after me? I need to tell you something that will help you take better care of me. That's called self-advocacy. The next one is, I'm struggling with some feelings and I don't know what to do. Is there someone here who can help me? I have to tell you that it may not be your doctor. So let's repeat that together. I'm struggling with some feelings and I don't know what to do. Is there someone here who can help me? And that may be a social worker, that may be a navigator, that may be a nurse, that may be somebody that is going to connect you with resources. And the last thing is, this is important. I really need you to hear this. This is important. I really need you to hear this. And all three of those are things that will stop a doctor in their tracks and prompt a consideration of how to help. So one of the things that we struggle with in survivorship and in surveillance is managing uncertainty or fear of recurrence. How many of you would like get a CAT scan every week if you could? Yeah. And I think that uncertainty is a normal part of the human experience, which is magnified when you have been told that you have lung cancer. There can be a range of emotions that you don't know how you're going to feel every day. And it can also feel like I'm being told multiple things. Do I have a recurrence? Is it just radiation change? Do we need more treatment? Do we need a biopsy? And so that not having that certainty, we as human beings are still very animalistic in that we want a black and white answer, or we want a yes or no, off or on, cancer back, cancer not. And living with uncertainty is something that I have learned as part of the survivorship experience. I want to say that living with uncertainty is normal. It's something that I hear from every patient who's heard the word cancer and every caregiver and co-survivor that's heard that as well. And this is not something that humans are naturally good at. Most patients will tell you, and I encourage you to find the long-term survivors here, that uncertainty gets less over time, but never completely goes away, particularly when a scan comes up, someone else is diagnosed, or you hear about something on television. You should know that you all have done all you can do. There are some things that even if you decided X instead of Y, or maybe you should have gotten a second opinion and you didn't, you have to look in the mirror and know that the person that's standing there did everything he or she could possibly do in that moment, and the rest is not up to you. The other part is your treatment team will be with you. And I also encourage patients to really think about and utilize ways that you have managed uncertainty before. These are small examples compared to a diagnosis of cancer, but letting your children go off to school, the first time a teenage driver starts driving, starting a new job, or even doing something like this where you're speaking in front of a big group of people. All of those are uncertain things. We don't know what's going to happen when we make that next move. And so what worked for you in the past? That I think that's it's good to look down at your tool belt or at the people around you and think, okay, how did I do this before when those fears of recurrence or uncertainty start coming? When to call your doctor. People are also in uncertainty, especially I think in what I call the acute survivorship phase. I think it can be hard to tell when you should call your doctor. Obviously, when you're a triathlete crossing, the finish line at the Paris Olympics, don't call your doctor. But if you're come across a cow that's stuck on a fence, well, don't call your doctor. But you could call. We have cows and horses, so you could call me. But better to call a farmer that can help. But I really give patients permission. You are not bothering us. We would rather know more than less. And I can be so much more effective without the help of Dr. Google than I can with his or her input. So with my chart, there are nurses that are looking at my chart all the time. There are people that are helping us with communication. And so rather than the ready availability of answers that we all have at our fingertips, these are some definite times that you should call your doctor. If there's something severe, if there's something inside you that says, I should probably go to the emergency room for this, and you're willing to leave whatever you're doing and go to the emergency room, that's definitely a time to pick up the phone and call your doctor. If there's something that is new and even if it's been about 2 weeks, that's something to call your doctor about. Should you start with your primary care physician? Should you start with your oncologist? That's up to you and your relationships. You can reach out to both. But you really are not bothering us. We would much rather, it's so much easier to go through and say, oh my gosh, that's not a big deal, or yeah, maybe we should bring you in. And then also if you have a medication that has been given and all of a sudden it stops working. So it's been working for a long time, like for pain medication or something to help with your breathing, and it's no longer working, that's something that we need to know about as well. So if you need permission to talk to your doctor, then I'm hereby giving it to you. You can say Dr. Wentworth told you to call me. It's fine. The last part of managing uncertainty is to find your dream team. So when you enter the cancer world, we immediately take all control away from you. We tell you where to go, how to be, keep your phone next to you. We're going to be calling you. We're going to be switching. You're going to be waiting. We're going to be doing this. We're going to be doing that. We're going to be poking, prodding, getting you to sign up for all sorts of crazy things and sign a bunch of forms that you don't have time to read. And we do not do this transition well. Survivorship moves from a very paternalistic and prescriptive approach led by doctors to more of a collaborative approach with you as the patient in the driver's seat. And we don't really do that transition of defining the relationship very well with you. So I think, again, as you move into survivorship, a lot of this goes back to you, A, because we don't have a lot of the answers, and B, because it becomes more collaborative. It is more what symptoms are bothering you. What is the one thing that I could change that would help your quality of life? Why are we doing this? It's really becomes a very patient-driven relationship rather than a doctor relationship. And because of that, I think it's also important for you to bring in other people. Our training, our expertise, our spiritual gift is helping to cure cancer. In the survivorship space, there are other people that can help you heal way better than I can. I am not great at advocacy. I'm actually really not great at public speaking like this. I'm a terrible group leader. I've learned from doing that with social workers because I'm just like, well, just tell him that you don't like him. Next problem, go. Just do this, just do this, just do that. Like the social workers are like, okay, Dr. Wentworth, people just need to get their feelings out. I'm like, well, leave that lady. She's crazy. Like, get out of here. Go, go, go. Who's next? Who's next? Who's next? So we may not be the best people to manage the uncertainty of survivorship, but you have people in your life, and it may not be the same people that went through treatment with you. It may be groups like this where you can say, I have lung cancer, and you're not going to get the look. So figure out who that person is that can help you keep you accountable, that can help advocate for you when you go to your doctor's office, who can help pull you out when you're in those times where you're wondering if cancer is going to come back. And again, that's your A-team, and everybody in this audience hopefully is old enough to know who the A-team was. But each one of them had a special skill set that when it all worked together, they worked together to solve problems, which always seem to be strange self-made problems. But in this case, I remember the 1996 Olympics team, and they were mostly Chicago Bulls, which I was from Illinois. So yeah, give it up for the Bulls when they were good. Yes. And each one of these are premier athletes that have worked very hard on their craft. And that is the same for every single one of you who are all survivors and all have something to add to each other. And then there are people that are around you who are really superstar athletes and supporting you in this new journey. These are some of my favorite resources in addition to LiveLung, and you guys have probably talked a lot about these. And I also do a Substack that you're welcome to read and that you're welcome to subscribe to. And I recently released a podcast that talked about why we aren't further in curing cancer. So that's sort of where I'm at. Oh, yeah, totally. Yep. Yeah. I just went to Snoop too fast. Yeah. Yep. Those are my favorite resources. Livestrong, which a lot of you know about. Hirsch Wellness is a great organization out of Greensboro that does a lot of the journaling, processing, photography, art work that helps sort of process the survivorship experience, to process the trauma of what it is to be a patient. And then obviously Julie, I'm sure, has talked to you guys. Julie Lanford is a cancer dietitian, and she has great, when somebody tells you you should go on a keto diet or should you eat sugar, or if you have questions about which supplement is best, Julie's really, should you eat organic or not? Julie's really great about that. So that's where she keeps up with all the evidence on that. So I really enjoy her. And then this is just how to get a hold of me. And I'm happy to take your questions, hopefully. This is like Stump a Chump, and I've probably heard all of them, but I'm really very honored to have been here and happy to answer any questions. Yeah.
And questions?
Real quick question. I'm stage 1A, had the surgery, out in 3 days. He said, walk, walk, walk. No chemo, no radiation, no medication. Yeah. I don't know who my team is, if there ever was a team.
Yeah.
And it's 9 years now, so I have no clue.
Congratulations. Yeah. And that happens with early stage disease, that we say everyone's great and go off and be on your own, and now who's watching you? Mostly after 5 years, there is a great transition to patients to their primary care physician. That again is not well communicated to patients, that we no longer think that you're at high enough risk to be followed in oncology. So that team would be your primary care physician, but there are always resources available for you at every cancer center, whether you need to pay a higher specialist copay or there's any benefit to going and waiting in long lines at a cancer center rather than just talking to your primary care physician about how to monitor for lung cancer recurrence is not well studied, but in most lung cancer survivors after 5 years, we're transferring patients back to their primary care physician who can order or discuss the pros and cons of ordering follow-up imaging. Yep, yeah. But I admire you for connecting for groups like this, because I hear this from Hodgkin's disease survivors that are 20 years out from treatment, and they're like, I just got dropped. Like after I was 16, nobody ever contacted me. So finding groups like this is really important.
And I'm 19 years out, and I don't want to stop my annual screenings and all that. So yeah, I'll continue on. So it's a personal decision and what people feel best about. Questions for Dr. Wentworth? Katie?
Thank you so much for your presentation. I really enjoyed it. I don't know if you have an answer for me, but I promised somebody that I would ask this. Do you know of any research going on in LMD?
LMD.
Yeah, leptomeningeal disease.
Yep, yeah. So most of what we're trying to do is in prevention of leptomeningeal disease. And there are new projects afoot to think about the immune system of the brain in a different way. If you look at where we are in lung cancer treatment, most of it was keeping systemic disease. The brain and the brainstem have always been something that has been very difficult because it's so hard to get stuff in there. And so a lot of the work is in prevention of leptomeningeal disease. And they're looking at new ways. We used to think that the brain and the spinal fluid didn't really have an immune system, but now we're thinking about that in a different way. It's maybe that just the immune system that the rest of our body uses can't be turned on in the same way in the brain and spinal fluid. So I think that there are people that are looking at how do we get the immunotherapy or the targeted therapy that some of you are on or some of you have had, how do we get that into the brain in a safe way? So we can prevent leptomeningeal disease and we can treat leptomeningeal disease, but most of those treatments also kill the brain, which supports the human that's in there. So that's really the balance of trying to get to leptomeningeal disease. But I think that I have felt the most hopeful about cancer, and I'm an oncologist, so I call myself realistic. My husband calls me negative. He's like one of the most positive people. But I've heard too many miracle cures come and go, and I've seen too many patients' hopes be dashed, that you have to have it clear a really high bar for me to believe in you. And I think with targeted therapies and immunotherapy that I can stand here today and say, I think we finally understand that we have to start working with our bodies instead of trying to poison our bodies and hope that they recover. So I think that finding that it is, and this is some of what I tried to communicate in my podcast because I couldn't wrap my brain around it, cancer is going to become more complicated. And as human beings, we don't like complicated. We like, here's your treatment, here's your CAT scan, you don't have cancer anymore. But as you all are starting to experience, I mean, how the medical oncologists keep track of BRAF positive and EGFR and all the things that you guys educate yourselves on, That has happened in 3 years. We've had that happen. And so I think that this one thing that we've called lung cancer, and so in antiquity called small cell and non-small cell lung cancer, which is like so crazy, that is a broad spectrum of diseases that are going to become very specific to the patient whose body that those cancer cells formed in. And so I think we really need to develop, as physicians, a humility, and as patients, a embrace of complexity, that your care and your diagnosis and treatment, especially the people that came beyond you, it may be that instead of doing surgery for a stage 1 patient, we just give 1 dose of immunotherapy and you don't have to have surgery, and then your body takes care of that tumor. And so as humans who still like really believe in the surgeon's knife. I mean, I don't know if any of you are treated in Greensboro, but I'll say when Pat Burney, who's a wonderful cardiothoracic surgeon in Greensboro, when he retired, I was like, can you just like look around in my chest and make sure that like nothing's wrong before your hands retire? We so believe in the knife, and I think that we're gonna have to release that and start really thinking about cancer as a disease of our bodies and how we can use our bodies to really fight that internally and reverse those changes, rather than doing something that seems so drastic as to rise to the level of something as drastic as cancer. I don't know if that makes sense, but that was a long answer to leptomeningeal disease, but yeah.
Hi, good morning. I was wondering if there's any common denominator that you see with long-term survivors?
We don't, not yet. Not that we know of, and that's the hard part. We have just, you guys are going to, you're going to be like the wizened old, like, I guess I think of the Barbie movie, like I think of Kate McKinnon, who's like the crazy old Barbie on the mountain, if any of you guys watch that movie. That's going to be you guys. You're going to be like, back when I was a survivor, they just did CAT scans. And so we are just beginning to even look at the difference molecularly in the original diagnosis, let alone at the final diagnosis. And I think that we're also changing the way we do clinical trials. So it used to be you treated half of patients one way, you treated half of patients another way. We spent $1 billion following patients for 4 years, and then we figured out that this one drug you have to take for 2 years. Well, every pharmaceutical company in the world would love for their drug to have to be given for 2 years. But instead of that, what if we move that back? And what if we just give you enough that you have a response that we know is going to cure your cancer? It may be 3 months for you, and it's going to be 2 years for him. We don't really care about how much drug you get. It's the response that we really want. And so I think that as we open our minds, and this is scientists, this is basic science researchers, this is industry, this is statisticians that have to set up these very complicated trials, I think we're going to see a lot more individuality. And I think that the response rate, the responses of how people of responses to initial therapy is going to predict the future. So I think it's coming, and I think that people will be monitored differently after treatment based on their responses and based on their individual tumors. Mm-hmm. Yeah.
Like I'm a 19-year survivor, made a 6 years extensive stage small cell, no recurrence. Terry Gillespie, where's Terry? Anyway, she's 21 years out, and
Yeah.
we should be part of a clinical trial. Like, why did their treatment succeed? Why are they thriving? And instead of like, you're
Correct.
done, move on.
We're working towards that again in the breast cancer world. They're working towards that, and I feel like we've just lumped lung cancer screening over the finish line. But honestly, what we need to be doing is we just finished that trial, and we're still only screening about 10% of people that need to be screened. But low-dose lung cancer screening only catches about 8 more cancers. It's not good enough. It's still cancers that are visible on a CAT scan. We need to find it in circulating tumor cells. We need to find it in sputum. We need to find it before we can see it on x-rays. So what I'd really like to know is not do we need an annual screening lung CT every day, which I think we absolutely should have for every person who is at risk for lung cancer, or every year, not every day. As a radiation oncologist, I love radiation, but even that's a little much. So I think what we need to do is figure out who needs to be screened and who, like Dusty said, like who is not going to develop cancer. I mean, we all know people that were exposed to asbestos in World War II that never developed lung cancer, or that were smokers and never developed lung cancer, or who weren't smokers and developed lung cancer, or who didn't respond to the same treatment that somebody else did. So again, this is the complexity that I think is even going to start in screening. And I think that's where we need to figure out what is it about our own bodies, because cancers don't grow in a petri dish. They grow in our own bodies. Something goes wrong in our bodies to develop any human disease. How can we best manage that thing in our own bodies rather than just trying to attack it as we do, weed in our yard or something like that? Yeah.
I had asked my doctor about chemo brain. I know we all suffer from it. And she said there's actually not a true diagnosis and there's nothing that you can do for it. And I just have a hard time accepting there's nothing I can do for this. I mean, just a simple getting dressed. It's like, okay, I'm putting my, shorts on before I put my underwear on. Now I got to take my shorts off and put my underwear. I mean, just crazy things that happens on a day-to-day basis. And she said some doctors, physicians, doesn't even acknowledge that chemo brain exists. It's just like all in your head. It's just due to the stress of the disease. And she said with me having chemo twice back-to-back within 2 years of time that, and the stress and everything. But anyways, I just wanted to know your thoughts or anybody else's thoughts of how do we help ourselves get better in this situation?
Well, she's correct. There's the hard part with medicine is we can't diagnose anything if we don't have a test for it. So we don't have a test to diagnose the cognitive impacts of cancer treatment. And there are several trials that look at just after a biopsy, patients do have a reaction that can change cognitive function even after having a biopsy or even after hearing the word cancer. But we also know that there are some patients that are more susceptible to one dose of chemotherapy or 2 rounds of chemotherapy than others. And I think that what we're doing from a treatment side is trying to get chemo. We know chemotherapy is the worst of that. The immunotherapy is not as bad, doesn't seem to have the same cognitive effects as chemotherapy. So we're trying to get true chemotherapy as we think of it, out of treatment as much as we can. And trying to figure out who would be at risk for cognitive effects. There is no evidence-based guidelines for treatment of cognitive dysfunction or chemo brain after treatment. The medicines, the Ritalin, the Aricept that we use for dementia and that sort of thing have not shown to be a benefit in patients that struggle with that. So I acknowledge you. I think it's totally real. It is all in your head, but it's in your head. And that is something that patients struggle with. And I really admire you for continuing to work through that, because I think that it's, again, if you had purple spots on your face, everybody would be like, wow, purple spots, that's really something. Did you get that from your cancer treatment? But when it's internal, it can be very frustrating because it's not as external and people aren't as aware of it.
I'm with Donna, and it's been 6 years since I was treated, and I didn't have immunotherapy because it wasn't approved for small cell at that point.
Right.
But my question is, I'm aware that there are some labs studying blood biomarkers, blood markers for small cell. How realistic is it to think that they may be able to test our blood at some point?
Yeah, the hard part is, so I just watched the National Coalition of Cancer Survivors just had a great discussion on early detection with Otis Brawley, who's at Hopkins. He was at the American Cancer Society. And I was like super excited. I was like, oh my gosh. And this is multi-cancer early detection. So this would be like, hey, can you get your blood drawn and you can detect colon cancer, pancreatic cancer, lung cancer. You can just do one panel and not have to have mammograms and all that. And he said the difficult part is in some of these trials, first, there's no FDA approval for any blood test. So There are labs that will do it, but you can only, to get FDA approval, which basically means payment, you have to show a survival benefit. So you have to show that people live longer, and there haven't been any early detection for like circulating tumor DNA or anything, microsomes or anything like that. So the hard part is, okay, so we detect cancer in the blood. We know 100%. If we find, XYZ DNA in the blood, then we know with 100% certainty this person's going to get small cell lung cancer. Then we do a PET scan or a CT scan or an MRI scan, and we don't find anything in the body. And that is the hard part, is then now we're so early, how do we bridge that gap between we can't see anything? Like, do we just give that person immunotherapy? So I think first is the development of the test, and then it's, okay, so now we found it before we can see it on a CT. What do we do with that person now? So I think it's both the development of the test and then that treatment is going to be the difficult, it's going to be the difficult part. And they'll probably ask some of you guys to be a part of that, I would think. Yeah.
Who would you suggest is your top A team members? You know, your oncologist, your primary. Who else would you suggest that we have on our A team?
The people in your life who want the best for you. If it's your sister, if it's your best friend, if it's your husband, if it's your child, if it's a survivor in this room. And I think it varies. As a baby oncologist, I thought, well, of course, you want to tell the whole world, like everybody's going to come and support you. And I quickly learned the crazy things people say when you're diagnosed with cancer. And now I'm like, don't tell anyone. They're going to say crazy stuff to you and feed you asparagus juice. Just keep it to yourself. For the love, do not tell anyone. So, and it's that person, you might need a cheerleader. You might need a running back who's going to be the person that, I'm terrible at football, who clears all the people away so you can get what you need. So I think it's finding that advocate. It's the cheerleader. It's the person that can just listen to you vent, and that. No. Health team wise and survivorship, I think that's the shift, is that your health team moves into the background and it's more of your personal team that helps you manage life after cancer, which really only probably about 15. Yeah. Yeah, I think that's different for every person. Yep. Yeah.
Okay, hi.
Yeah.
Couple of things. First question is, I have a nephew, 38, lung cancer, very aggressive chemo. What's the percentage of 40-year-olds and under getting lung cancer? And when they found it, they said stage 4, but he's 38, so they said age was on his side. And they use numbers like 95% survival rate. After 2 months of chemo, which is twice a month, he took the CAT scan a couple of weeks ago, and they said they didn't see any cancer.
That's wonderful.
Sounded real good.
Yeah, that's
but
great.
But I've never heard of a 40-year-old or 30-year-old getting lung cancer.
Yeah.
While I'm a cervical cancer survivor, this is my partner, she has the lung cancer.
Yep.
Oh, and another thing, when you answer that percentage rate, I need you to explain to me, I heard something yesterday for the first time. What's chemo brain?
I'll leave that to the survivors. They can describe it way better than a doctor can. But that is the difficult part, and we struggle with this in all cancers. So there's this rise in young people with colon cancer. There's a rise in, we don't catch the most aggressive cancers, we usually don't catch with screening. And that's where screening falls short. So we don't screen, like your nephew was not a candidate for screening. And those are the cancers that we're not catching with screening. So how do we start incorporating catching fast cancers. It's the same thing with a lot of aggressive breast cancers aren't caught by mammograms, or they'll have a mammogram, and because it's the most aggressive cancer, and the same thing with a lot of lung cancers, it grows in that 1 year before the next lung. So we need a better screening tool. So I'm excited about your nephew, but I don't know his specific case. It's hard to comment.
Thank you.
Yeah.
Thank you for
You're
your
welcome.
presentation.
Yeah.
A quick question. I've been seeing a lot of commercials regarding the Gallery tests. Have you heard of that?
I have not.
Well, this is a blood test that can detect different forms of cancers, but not all cancers.
Yeah. I think that again goes back to the hard part of developing these blood screenings. I mean, it's like 23andMe, it's like all that stuff. Okay, so what do we do with that knowledge? Unless we can diagnose with someone with cancer and then we have a treatment on the other side, just giving someone a test that says, yeah, you have lung cancer floating around, well, then it's like, now what do I do? So I think it's pairing the detection with something to do about it. And that's where we're kind of not where we need to be.
Okay, and then real quick, I thank you for mentioning advocating for ourselves. I know when we go into a diagnosis, we really don't know what to do, where to go.
That's right.
But once we get it, whether you 1 year clean or 20 years clean, we still have to fight for the cause, because when I'm looking at, if we don't advocate, then we're still at a standstill with what we're trying to communicate to the world.
Yeah,
Thank you for
it's
that.
true. You're welcome. Yeah.
Thank you, Vicki. We got Jackie and then Linda. And if you have a question, raise your hand so I'll be sure to come and get you.
Just one of the things that she had mentioned about her nephew who was 40 years old, okay, and they possibly could have lung cancer, whatever. But are oncologists and whatnot, are they becoming more aware and getting training in environmental factors?
No.
Right on.
Yeah.
Right on?
Yeah, exactly. No.
P-
That is public health rather than what we're trained on
Than
as
what you're-
oncologists. Yeah. That is more prevention, and we are trained in treating, and that's the whole, how medicine was divided up in the 1950s is a whole thing. But not really, because it's also just there's only so much you can learn and so much you can be an expert in. So it's really the public health space.
Yeah, see, that I'm about 20 minutes from East Palestine, you know, the
Yep. Yep.
and those people there are suffering, and
Yeah.
it's terrible. So I was just curious, okay, do the oncologists or whomever say, okay, you can get a CT scan because you just got hit with massive amounts of chemicals.
toxins, yeah.
Exactly, exactly. So
Yeah.
I know it's a huge issue.
It is.
Yeah, thanks.
Yep. And especially in the communities where those plants are built, which are usually not communities that have been advocated for. Yeah.
I just really wanted to thank you.
Oh,
You're
thank you.
actually a wonderful speaker. I ditto what Maida said.
Is my mom in the audience? I feel like my mom's here, but thank you. Thank you.
For me, when you were talking, so I've been diagnosed for like 4.5 years, something like that. And I never really understood. I'm a very need-to-know kind of person, which I'm sure a lot of people in this room are. So I really struggle with, when I first got diagnosed, who the hell do I go to? Do I go to my oncologist? Do I go to my PCP?
Yeah.
Never really knew. But you really opened my eyes today as to why. Like, I was really thinking about changing my cancer center because they did exactly what you said they should be doing, right? They don't tell me crap, right? So you really opened my eyes, and I'm navigating this thing, starting to navigate it better. I also do social work kind of stuff, and I advocate, and I advocate real strong for my people. I really struggle when it's me and when it's something like this.
Yep, that's very common.
And I need an advocate for me.
Yep.
And now I'm going to ask those 3 questions, and I'm going to find somebody for me.
That's right.
Because I need it.
Yeah.
So thank you.
Good job. Congratulations. And thanks for the work you're doing for other people.
I have to agree with everybody about your public speaking.
Oh, thank you. Hopefully I can like convince world leaders to do survivorship when I go to Paris. So,
You know, when I met LiveLung and Lynn and Dusty and everybody, I met them through a webinar, right? Because it was in the middle of COVID. And I am a listener at first, but then I can chat a lot. And one of the things that I have learned through this journey, almost 5 years, is to listen. And listen to everybody. Mm-hmm. Because everybody has something to offer. And you don't know what you don't know, okay? So for me, for example, one of the things that I learned was liquid biopsies, right? I didn't have a biomarker, even though I had, multiple bronchoscopies and everything to try to get one. So I went to my doctor and I said, hey, we've tried biopsies a bunch of times. Why can't we try a liquid biopsy? And then he says to me, yeah, we can. But typically your insurance won't cover it. And I'm like, well, let me decide that. I'll refinance my house if I have to, if that liquid biopsy is going to help me.
That's great.
And so
Yeah.
a lot of times, it's not that they don't want to do it. A lot of times is that it's the insurance that they're so worried about, also that it doesn't come out of your pocket. Mm-hmm. But let us decide that. Yeah. So inform us, give us information as much as possible, but also learn. And that's, I advocate for myself all the time. Mm-hmm. And every day I show up to my 3-month appointment, I'm always telling my oncologist, hey, I heard this. Can we do this? Can we do that? And she's very good at explaining why and why not. But I love to ask because I hear it from all of you, and then I take it to her. Whether she decides to maybe venture into that, great. But she's excellent at telling me why not, the pros and the cons. Yep. And that is what I believe makes a difference in us walking out of that visit feeling confident that you have a team that explains to you, not that says no, and doesn't give you the explanation why. So ask for the reason why not, or why you're getting that treatment.
Yeah. You guys, if there are the movement for patients to start advocating for diseases started in the 80s with the AIDS HIV movement. The federal government would not have developed HIV/AIDS treatment if people had not been lying on and getting arrested, and all of that sort of advocacy around this disease is killing us. And there are going to be more of you than there are of people that are making the decisions on which cancers get funded. And so it is not fair, but there are passionate researchers, which Dusty and Lynn do a great job of bringing into you, but they need your faces and your voices, and it should be enough that you just survived cancer, but unfortunately you also have to be the ones in people's faces all the time about lung cancer. So when they organize Washington, D.C. days, there's no one everyone will take credit for curing lung cancer, but no one's out there thinking this is the reason I'm in Washington, D.C. is to cure lung cancer. So that's where it really becomes very powerful for you guys to come and say, I need this, I want this. What are you doing today to do this for us, and advocating in that way? Mm-hmm. Yeah. So
you talked a little bit about early screening and all of that. Uh-huh. My cancer was found by chance. Extensive stage at 43. Which is pretty insane. Yeah. So when I advocate for my friends and family and all of them to get screened, my age group is in my age group. So am I just wasting my time talking to them because they can't get screened, right?
Correct. Yeah. You are not wasting your time by advocating for early cancers in young people. And the difficult part in cancers that occur in young people is they're usually more aggressive in later stage, just like yours was. So you would probably find space and a different advocacy in what's called AYA, or adult and young adult cancers. And that is advocating, because you're so healthy, people would look at you and your wonderful sleeves and say, this guy can't be a lung cancer survivor. And that is what blinds us to what a cancer survivor is going to look like. So we need to develop probably different tools to be screening in people under 40 than people that are over 40 or that have the exposures. Like, there's just going to be a different answer. And so it's really important to have the different faces talking about cancer, because otherwise you just get pigeonholed, as all of you have been, as lung cancer survivors at one point or another. And I think it's important to have that voice out there and to raise awareness, because you can go into spaces that I can't go into, that he can't go into, that she can't go into. And there is somebody that is listening to you in the spaces that you're in, that you will never know who's there thinking, oh my gosh, my dad, my husband, my partner, my wife needs a screening CT. So it's sort of like dropping ink in water. It will spread through the water. It may not be right where you drop the ink, but that impact is going to have an impact on your community. And each one of us goes into different spaces and can talk to people in those spaces. So I think you're doing very important work. Mm-hmm. And I would continue.
Just one quick question.
Yeah.
Because you sound like you have your finger on the pulse of what's coming. Is there discussion of using like AI and getting around the HIPAA laws in some manner? Because there's a wealth of data out there that we can't look at, and we should be able to.
Yeah. I totally agree with you. I think that there is evidence that AI can process changes in lung cancer screening, or lung cancer changes or detection, or something that a human brain can't process. What I do know is that access to your healthcare records by anyone can be used for a variety of decisions, including if and when you can ever have health insurance again. So I think that we have to be very careful, and I don't know the answer to this, but de-identified databases are common in things like the SEER database. But what I personally think we need to do, if I was like director of the NCI, would be we need to enroll every single person who's getting a low-dose lung screening CT. We need to enroll them in a trial, and we need to learn from them. They do that in Europe. Socialized medicine is different, pros and cons. We need to, everybody who's doing a colonoscopy, everybody who's doing who's doing a mammogram, we need to follow them and learn from that, instead of spending $30 and $40 billion on cancer screening and not learning enough. But I don't know that I trust the tech bros in California yet enough to trust them with your medical information. But it may be happening, and there's nothing we can do about it. I don't know. My kids tell me that AI is already taken over my phone, so I don't know. But yeah, I think that there is going to be something there, that they're going to be able to analyze data a lot faster and catch more patterns and trends by zip code, by age, by exposures in your childhood, all that kind of stuff coming together, I think is where we're going to be headed. But who does that, and is it safe, and who regulates that, and who's the overwatcher? I don't know about that. Yeah. Okay. Yeah.
This is more of a comment, sorry.
Yeah.
But I think I'm not going to explain this very well, I don't think, but to people who are non-cancer patients, when you say that you're a lung cancer survivor, they think you are done over, everything is great, you're fine and dandy. It's like, I'm on ongoing treatment.
Yeah, living with cancer.
People
Sure.
so you're surviving cancer.
Yeah.
But when you say you're a survivor, they just think, oh, you're fine. No, I'm surviving cancer, but I'm a survivor also. I'm doing both simultaneously. But I wish they would understand that, because they don't get it when there are some days when I'm just too tired to do anything. Well, why not? And so I think that's where somewhere there, I wish there was a way to clarify the difference between totally survived and you're surviving with it.
Yeah. I think that we have a hard time as human beings looking at each other through the breadth of everybody's lived experience. Again, I think this goes back to us being very kind of primitive tribes, and we want everybody in our tribe to look the same, and we don't want any weakness in our tribe because then we're going to get killed by the saber-toothed tiger or whatever. But I think that living with cancer, if any of you are living with cancer, you can sometimes explain it that it's kind of like multiple myeloma, or finding the living with cancer movement is growing. And I think cancer as a chronic disease like diabetes and high blood pressure is becoming, people are becoming more aware of that. But definitely, I think that it's very common for cancer survivors. People either want you alive or dead. And like anything in between, they're like, ugh. And then you're dealing with their uncertainty and your uncertainty, and then you're explaining again. So don't tell anyone you have cancer, but advocate that people. But anyway, I really admire what you guys do, and thank you for having me. Good job, Rusty.